Good morning and welcome to Coffee with Ken. I'm Ken Biberai, a managing director at Savills, a leading tenant advisory commercial real estate firm. We are in week 57 of social distancing as a result of the COVID-19 pandemic. In the news today, President Biden has announced a commitment to reducing greenhouse gas emissions by 50% by 2030. 3 in 10 healthcare workers are considered profession after burnout as a result of the pandemic, according to the Washington Post. Today's topic is innovations in healthcare. We're joined by Anish Chopra, the president of Care Journey, Jessica Nuavandi, the co-founder of Honeybee Health, and Inder Singh, CEO of Kinsa Health. Great seeing all three of you. How are you?
Good.
Well, excellent. Well, listen, I think this is a unique time. Healthcare is front and center, and I'm remiss that we haven't been spending all of our conversations on Coffee with Ken talking about healthcare. But right out the gate, I think it'd be super helpful to hear just what have the last 57, is that what I said, 57 weeks been like for you personally, as well as founders, CEOs, presidents, leading organizations? Like, how have you managed? How's your team managed? How's that been? Jessica, I'll start with you.
Yeah. Thanks, Ken, for having me. As pharmacists and an online pharmacy, things have never really slowed down for us. And there's no such thing as really working from home. So we've been working around the clock in order to make sure that we're, meeting all the demand and helping people. And we've been fielding nonstop questions since last year about COVID and treatments and things that people have been hearing in the news. And of course, for me personally, I think there's been lots of ups and downs. And as a founder, it's been a wild ride, but I'm proud that Honeybee Health has been able to help so many people during the last year. But I know it's been a challenging time for many of us, but trying to do the work. So
that's great. And Inder, how about you? I used to check the weather in the morning. Now I got to check, health weather. Tell us about the last year for you, man. This is it's wild.
Yeah, we launched healthweather.us back in March of 2020 because we saw through our network of 2.5 million households that use our smart thermometers, here's one of them, and medical guidance apps, we saw unusual levels of transmission. We saw unusual levels of illness incidence. This was, as far as we know and others know, the first sign that COVID-19 was spreading in the country. We saw it about 3 weeks before localities. It was a whirlwind. We've been working on building out an early warning system for infectious disease for the last 9 years, and during the pandemic, it came to fruition. Personally, I'll say we've been very lucky. I can't imagine how hard it is on frontline workers and folks that can't go into their jobs. We're very lucky at Kinsa. We stuck around long enough to help, and our team has grown threefold in the last 12 months. And we're kind of on some people's radar screens. We were a small entity, unknown prior to the pandemic, still pretty unknown outside of the public health and circles and folks that are looking at healthweather.us all the time. But it's been a whirlwind for us, and we're very, very lucky. That's
incredible. And Anish, my neighbor, how you holding up?
Well, we're holding up. Obviously, Zoom school for the kids is a challenge for everyone. It's an odd reality that the team, we have about 70 some odd employees. We may have had our most productive year yet. And I say that we're trying to figure out ways in which we can be more open and collaborative. And as we think about return to work, we're actually thinking about what components of the experience we retain. Company town hall meetings, for example, have become much better attended and more impactful when they're done virtually, as an example. The year itself has been a challenge, given a lot of what we do at Care Journey is around the public-private data. And honestly, the country flew blind. Inder, thank goodness for the health weather capability. Our CDC was flying blind, in the beginning of the pandemic. I remember the first report by the CDC about the 4,000 COVID cases that they were studying had a footnote that said 92% of those cases did not include any clinical history or context of the patient. So we were trying to figure out, what would a healthy young person look like who may end up in an ICU versus a healthy senior? And what were the clinical factors that would drive the likelihood of being more severely ill? you can't answer that question if you're flying blind. So we were very frustrated and did our level best with the VA to write a paper on how you could predict through clinical history what the likelihood of an unfortunate mortality event would be. Sadly, the prediction models that the VA had designed actually held true through the pandemic, and a number of people under the age of 85, younger, presumably healthier folks with comorbidities might have actually been a little bit more loose with their social distancing and put themselves in harm's way, thinking that, oh, I'm not a senior in a nursing home, I should be fine. So my point is, Ken, the year has been professionally challenging in the sense of the country needed to do better in terms of its preparations. And again, we're all going to get back to some hopeful new normal in the not too distant future.
So we have a lot of business leaders who come on our talks, and when you're talking to kind of, I guess, a more traditional business leader outside of healthcare, COVID's been an accelerant for some aspects of it, but their model pretty much has probably stayed the same. They haven't necessarily had to change how they do business as a result of COVID. But being in healthcare, with each of your companies being a little bit different, how has the last year maybe transformed or altered your business model? Have you stayed to the exact model you had in January of 2020, or have you actually had to make hard kind of pivots to address greater need that you feel you're in the best position to address? And is that going to be a lasting thing that your company will stay focused on? Jessica, I mean, I feel like you're kind of at the forefront with especially access to medication and all this stuff.
Yeah, I mean, there's really been a wave, in the beginning, and off of what Anish said about seniors, we were really well positioned at the beginning of the pandemic to help a lot of people avoid going in to a physical location and getting their prescriptions mailed and that kind of thing. But then we started to realize, wow, there's a big segment of our patient population that just wasn't used to ordering anything online, let alone medication. And seniors were a big part of that. And so we really had to ramp up our, what we call them patient advocates, is essentially our frontline pharmacy technicians and pharmacy workers who speak with people on the phone and take orders over the phone rather than placing an online order. Had to ramp that up. We saw that I felt like we provided a lot more consultation than normal. And we were fielding so many questions from doctors and other prescribers about potential treatment plans. And it really felt like, and I'll get into this later about pharmacists gaining provider status, but it really felt like for the first time, we were being seen as pharmacists, as drug experts by the rest of the medical community. And we were at the front, and we were answering questions about, I'm sure you guys remember all of the craziness around hydroxychloroquine, and also known as Plaquenil, and other drugs like that. And we were really the first stop for patients when it came to panicking about what they should take or what they should do, or if they have a fever. It's been a crazy year, I'll say that. But our original business model, much hasn't changed. We've kind of, the reason we started Honeybee was because we wanted to provide a transparent kind of place for patients to go and get drug pricing that was consistent so they could have continuity of care, be able to choose what kind of medication was good for them rather than what the pharmacy normally would give them based on reimbursement. So we provide a unique experience where patients can actually choose their drug manufacturer so they can see if something has gluten or lactose or, that kind of thing. And, we've expanded our services to include custom, like premium supplement recommendations. So kind of mimicking the experience that you would get if you would have seen me in my community pharmacy. So treating you as a whole rather than just with, pre-manufactured medication. So if you're on a cholesterol medication, I'd say, hey, Ken, you need to be on CoQ10. And so we customize that experience on our site now so that we can do all of it for people.
Amazing. How about you, Inder?
Just taking a step back for a second, Jessica, Anish, and I, we all work in healthcare, health services, digital health, healthcare. The last year has been an opportunity for us to bring our missions to life. And I think that's true of many people in healthcare. It's been a catalyst for accelerating certain aspects of healthcare in a major way. Our business was catalyzed in the last year. We've been working hard for the last 9 years to build out an early warning for infectious illness. This is a completely new market, right? Trying to get the data insights that enable early warning and then creating a business model out of that early warning insights where you can sell that to someone and create sustainability and scale it. And in the last year, we've had all sorts of entities from employers to healthcare services entities coming up to us saying, we get it. We get that early warning is important in the epidemic. How can we work together? For us, this has been a real proof point, right? So again, taking a step back, in any epidemic, this is hopefully for everyone out there to think about the broad context here. Any epidemic, not just a pandemic like we've seen, there's 4 steps in trying to address it, right? First is early warning. Second is widespread testing and diagnosis. Third is treatment and isolation. This is a very complex, multi-step area, but the healthcare system understands this, right? And fourth is conferring immunity to the population. Today, we're doing that through vaccines. We've never had an effective early warning system for outbreaks, ever. The word early warning doesn't appear in the public health terminology. We talk about syndromic surveillance. We don't talk about true early warning. We now have it. That's what we've been working on. And so for us, it's just catalyzed our business model with many entities coming and saying, okay, like we get it, we understand it, we want those kind of insights. And we've been building out all sorts of features and products to enable the delivery of those insights in specific ways that entities can accept it. So to Jessica's point, let's just talk about a really important point that I believe is important to both the businesses Anish and Jessica have, which is seniors, right? You don't want seniors or those with underlying conditions going out to places where illness spreads, the pharmacy, retail, doctor's office. You don't want them going out in those moments where you're seeing spikes in illness levels, because if they don't have the disease, then they're going to get it or have a high chance of getting it. That's why we've seen a massive acceleration in these online services, a massive acceleration in telemedicine. And the real question for me today is, how do we preserve that progress and not take a step back? I was confident we were not going to take a step back months ago. I'm not as confident today that we're not going to take a step back. And we really need to preserve those great advancements in technology and business.
So 10 more seconds real quick and about how Kinsa has been tracking early warning, right? Like I love this kind of analogy of what data you were collecting before, and then how you were able to have that aha moment to realize that you were ahead of the curve and actually being able to spot and identify, right? Like just tell us that quick story real fast.
I'll give you a minute because it's too hard in 10 seconds. It might be too simple to say a network of millions of smart thermometers outperformed the US Centers for Disease Control and everybody else in early warning. The complexity is actually underlying that concept. What we see that the healthcare system doesn't see is we talk to mildly symptomatic people who never enter the healthcare system. They don't talk to a doc, they don't go to a lab. We also see things like intra-family transmission. How fast is it spreading in a household? We operate in 5% of US elementary schools. How fast is it spreading in a school? Those transmission data sets are perhaps the most powerful data sets for predicting what's going to happen in an outbreak. And as far as we know, we're the only ones to ever see real-time transmission data in the nodes of disease transmission. We also talk to people on multiple days of an illness episode, so we know how long-lasting or severe it is. And what we did at the beginning of the pandemic was look at those data sets and subtract out our real-time signal. We subtracted out what we'd expect from cold and flu season. So just taking fever alone, we saw fever levels rise all of a sudden in March across the nation, in the Northeast, in Florida, in Texas, in California, in Washington. And we said, wow, that's unusual. That's an outbreak. And then when we subtracted out what we expected, it was an unusual outbreak. It was the sign that COVID-19 was spreading across the country weeks in advance of first cases being confirmed in many places.
Fantastic. Well, Anish, I know you love data. So how has this kind of pivot been for you and the Care Journey team in terms of like identifying where you can even add greater value or maybe focus as a business?
Yeah. So this has been an awkward statement, which is the company grew 50% during the pandemic because of the demand for insights. So that on the one hand, this has been a hate to say it, a net positive on understanding what's working and what's not working. But really what it's done is it's shined light on what we've all presumed to be true, which is America spends more per capita on healthcare than any industrialized nation on earth, and yet we get weaker outcomes. The theory, that bullet point, we can all nod our heads and say, yep. But then when you get into the detail, you're like, well, wait a minute. Somewhere in America, there's a pharmacist who works for Jessica, who's advising through her advocate, a physician, a senior who sees maybe a primary care doctor who does or does not quarterback all of their care. But because of Jessica's intervention, that person avoided an unnecessary risk to hospitalization. So to me, finding the pockets of care delivery reorganization that have somehow beaten the curve in terms of what our expected inefficiencies are across the country, that's the job, in my view, is to, we normally take 17 years to get a best practice from the bench to the bedside in healthcare. We've got to make that 17 days or weeks, as close to real time as we can. And this concept of integrating pharmacy into the care team to make it one team, I'm not so sure, Jessica, you went all the way down that road, but assuming it does something like that and integrating some of the early warning indicators so that you could actually kind of, prepare with more. If we're worried about lockdowns, we can be much more surgical on lockdowns to very specific areas where the early warning indicators give us the flag, and we can activate the broader sense of care teams. So to me, Ken, the key learning here is we need to reform the way we are delivering care for the neediest and highest risk amongst us, and to demonstrate that we could actually give them better care at lower cost. And if we could find where that's happening, shine light and rapidly scale and replicate the results, we may come out of this with a more sustainable healthcare system that isn't a tax on America's innovation capacity, which it unfortunately currently is.
So a question for all of you, because I assume you've all had some pretty rapid growth over the last year. And if I'm not mistaken, in Q1 alone of this year, I think there's been almost $6-7 billion invested in digital telehealth type companies. Is this a bubble? Is this what we can expect to the future? Has the moment caught up that we really need to disrupt the entire healthcare industry in this country? And how are you seeing that, the massive influx of resources and investment, and where that should be channeled to make actual tangible improvements to care delivery across this country? And open to anybody. Just kind of curious.
I'll say that investment is definitely skyrocketed for digital health and health services, online technology-enabled services, and I don't think that's going away. But what I'm waiting for is that next step where we go to someone who has a change in health status. We go to them. We create the technologies that allow us to understand there is a change in health status out there, and we go to them. We're making progress as opposed to them coming to us, right? Because right now people have to get sick enough and start seeking care. This is the kind of thing that's going to be, this is an early warning system, right? It's whether it's for cancer, infectious disease, if we can catch it early, there's a far better chance of resolving the issue than if you catch it late. And I think that's intuitive to everyone, right? You can't make a dead cell alive, but if you catch it when it's dying, then you can potentially fix the situation. I think a lot of the investment that we've been making is heading in that direction. Again, this idea of telemedicine, instantaneous access to a doc, the work that Jessica's doing in terms of technology-enabled pharmacy services. But I think we've still got a long way to go to get to that point where we're going to people when they have a change in health status, and we're going to people in an equitable fashion, where we're even going to the underserved, the underinsured communities. That is a huge gap in our healthcare system, and we really need to make progress against both of those, is what I'd say.
Yeah. If I could just go, I think really the genie is kind of out of the bottle, and people know that they don't always have to go into a doctor's office for a simple consultation. They can do a video call instead, and they don't need to drive to their chain pharmacy, then wait in line and debate drug pricing. They know that there's other options out there, and I think this is just the beginning of that. I really don't think this is a bubble. I think this is the beginning of huge change, hopefully. for patients and yeah.
So I think some of that change is tied to regulation, is tied to government. I think COVID obviously has accelerated the reduction in barriers to telehealth, right? Like to have a video conference with a doctor, maybe it doesn't have to be in your same state. It could be somewhere else geographically. Anisha, somebody who obviously spent some time in government, how do you think about the regulatory framework around fostering innovation in healthcare?
Yeah, so we gotta move. We have 3 rocks to move, Ken, in order to unlock a delivery system that does what Inder described and Jessica, highlighted. Rock number 1, the way we pay for care has the perverse incentive of almost compelling that physician visit in the office in order to get a routine checkup. In other words, the ability for Jessica's advocates, if that's the right term, to offer a value-added service that results in a reduction in unnecessary hospital ER visit, that's not a billable event, in a traditional fee-for-service system. So coming up with a reimbursement model that would allow us to just treat each other like friends and neighbors, and reward each other for just normal behavior, right? That was door number 1. Door number 2, unfortunately, is that our siloed and fragmented health system means that the data that Jessica is collecting, maybe on a mobile app for the patient advocate or through some digital transaction, there's no easy button that connects that with the primary care doctor or the health plan care manager. So everyone's sort of in a silo and we're missing each other's key signals. Hey, by the way, Jessica, for that person who uses your pharmacy, next time they call you, could you ask them about this? Because we need them to know about that. That didn't happen in our system, and that's ridiculous. So we have to find a way to stitch. And then I think the third thing is we have a lot of this regulatory overhead. In a world of fee-for-service medicine, we had to put guardrails constraining physician financial involvement in models because we worried about them having some kind of incentive to increase the utilization or to constrain the supply of providers only to the in-state, because if somehow you're a doctor in Tennessee, you're practicing medicine in a different way than in Virginia. So if you look at these 3 rocks, in a bipartisan move, we've seen progress through the pandemic in all areas. Now there's an accelerated move to create a capitated budget so we can more thoughtfully reward Jessica for the services she does, and to maybe even bring in a revenue model for Inder to tap the early warning indicator for a broader population. Now that's a thing, you can negotiate. The second area, we're seeing these interoperability rules make it crystal clear that if you fail to share the data at the request of a patient, maybe Jessica's patients might say, you know what, Jessica, I've got Dr. Smith. Can you connect to Dr. Smith? And if they facilitate that, and Dr. Smith says, no, who's Jessica? Why am I connecting to her? There's fines now for blocking access to information, which is as of April. And then last but not least, I do think the telemedicine waivers did give us the window now where all these constraints on waste and overuse, in a world of value-based care, we can be a lot more liberal. Hey, virtual, physical, doesn't matter, you're managing a budget. So all 3 of these things are creating the conditions, I think, for a really interesting new model of healthcare delivery if we put the systems integration time to get it right.
Jessica, as you think about your model, I think so much of it is tied to transparency and cost, right? So tell us a little bit about how you created Honeybee, what you're trying to solve for, and what you're hoping to educate the general public on as it relates to cost and access to prescriptions and drugs as needed.
Yeah, where do I start? I think what Anish said is perfect. There is a lack of communication between everybody, and in turn, the patients suffer. And everybody is siloed, and that especially is apparent when it comes to paying for drugs. And somebody could be paying $10 for the same generic medication, and somebody could be paying $150 somewhere else at another pharmacy. And this is kind of where the idea for Honeybee really was brought about, because as an independent pharmacist, working in a small community, about 40,000 people, I realized I really can't, my hands are tied. I can't do much because everybody is operating on their own island. They have their own insurance. They're either get it through their employer, they have Medicare. And the disparity was unreal. And I realized that if I was going to help, then we had to work outside of the system. And that's unfortunate because there's loss of data, there's loss of communication, there's so much that happens, but people need that. People are, and now we're now seeing more and more providers, more and more pharmacies, more and more people work outside of the traditional system because that's the only way we can help people. And it's, you know, it's sad, but this is the way that our country's been kind of set up. And so really the impetus was, let's work outside of the PBM model. Let's work outside of the traditional insurance payment model and say, we can cut out all the middlemen and give patients direct access to and transparent pricing to generic medication specifically, but everything else as well. And in fact, everybody can have the same price. And we can give this service to the whole country, and we can cut costs by having one location and distributing out of that one location. It's you know, it's been a wild ride, but it's been very fulfilling. And I kind of want to go back to what Anish was saying about filling in the gaps and how pharmacists can really help there. You know, if we were able to get reimbursed for services or be recognized as providers by HHS, Medicare, then we could do more. In other countries, patients can walk up to a pharmacy for acute conditions that are self-diagnosed, plenty of other conditions, or come as a follow-up to chronic disease states like hypertension, asthma, and go to the pharmacy, get what they need without having to pay another fee to the prescriber. This needs to happen here as well. We need to give patients better access to care, and having the pharmacist be a part of that is key. And the time is now to do it, especially as we see what's happening with administration of the COVID vaccine. We would not be vaccinating as many people as we are now without pharmacists. So I can go on and on about that.
Yeah, no, this is fascinating. I want to build on that, right? So, Inder, when you were talking about where we are today, and a month ago, you felt better about early warning and moving forward, you kind of expressed a little bit of concern. Well, what are you worried about today? What are you worried about 6 weeks from now? What are you worried about, you know, in the next, by the end of the year?
Reflecting a little bit of what Anish and Jessica were talking about, a lot of this is about informatics and communication and streamlining transparency. It's a lot about the informatics side of it. I mean, Anish is one of the thought leaders around like how to advance the system with respect to say, informatics and technology and data. And so, you know, I'd love to hear a little bit more from him about what he thinks needs to happen immediately here to sort of take advantage of the momentum and keep the momentum going. But what I will tell you is that as I've peeled the layer of the onion back and looking at this, you know, we get stuck in places. Like, listen, healthcare is probably the only industry, maybe not the only industry, where faxes are still used. Faxes are still used very frequently. Just to give you an example of how challenging operating in healthcare can be, we've got all these fancy technologies, but we also have these 40-year-old technologies that are still embedded. And, you know, again, I would love to ask Anish what he thinks that need to happen, but I also want to emphasize this one other point is, if you look at our public health infrastructure, separate that from healthcare for a moment, just the public health infrastructure. We're talking about technologies that are very biased towards 40-year-old technologies. Like, we need to invest in our local public health departments and upgrade their informatics, their ability to communicate, their ability to see information, their ability to use that kind of information. We're stuck really far behind. So as I peeled the layer of the onion back, that is one of the biggest challenges. Anish, I'd love to hear your thoughts about how we're going to keep momentum here. I mean, again, Anish is absolutely one of the thought leaders around this area.
Are you pro-fax or anti-fax, Anish? What is it?
I am pro-fax to remove the facts. FACTS to remove the FAX.
Yeah.
There are, let me peel the onion back on the world that I wish to see. In my opinion, the big rock to move right now is we need pockets of the country where we rip the Band-Aid and build a whole new model. The Biden administration put a hold on an idea that may come back stronger, which was probably the biggest experiment in change in healthcare delivery reform we've ever seen, and since, of course, the creation of Medicare. And that is what's called the Medicare Geographic model. What they explored was, let's pick 4 to 5 cities or rural communities where we want to basically throw everything in the kitchen sink into the model. We want Jessica to make that the centerpiece of where she can build the new model. We want Inder to make sure that his early warning is part of the DNA. We want the public health system upgraded. We want to create this future architecture. And they have pre-qualified 10 cities as candidates, cities like Miami, Tampa, San Diego, Houston, Dallas, and so forth. I believe creating a test bed where all 3 of these trends can be built and deployed and learned from on the ground is the model. And the reason these 10 cities have of potential is there's a ton of money that's being spent on healthcare. And if we simply reallocated it to their highest and best use, there's enough money to fund Jessica's advocates to connect the dots. Much cheaper intervention, to get the early warning sign from in there, to figure out where we can be surgical in our public response. That is the big rock to move, okay? 2022, let's show the world what can be done. Rahm Emanuel called this a beacon community, and we were maybe a decade ahead of what was feasible at the time. So if we revisited the beacon community in 2022, we would really have a lot to show, number one. Number two, on the flip of that, we need to have a clear business case for reform, and that can be done today at the behest of a patient. Now, Jessica, I don't know if any of your pharmacy customers happen to be Medicare patients. I don't know if that's an eligible service, but let's just, Ken, for the sake of discussion, say the following. Jessica might treat 1,000 Medicare patients, and she can control her world and no more, no less. She could say, you know what? I want to be the quarterback for your patients. And that may not be what you want to do, as we were meeting for the first time, so I don't want to put words in her mouth. But you know what? Sign this form, patient X. You get to keep your Medicare fee-for-service benefit. We're not switching you to a managed care plan. You stay. But I'm going to be designated to be your quarterback. And I'm going to bring in there, and I'm going to bring in others, and I'm going to do something to stitch these pieces together. In a micro way, she can do the geo model herself. She can basically say, I want to quarterback this primary care relationship, and I'll drive it, not be a supplier of it. I think that's one of the most exciting programs. That's called Medicare direct contracting. And we're going to see this experiment. So you see, I work with companies like Walgreens and Village MD. They're going to be placing these clinics all over the country where they're going to take responsibility for the total cost of care. So we want to equip individual innovators with the tools to really drive change. And we want system level change. You want to have a barbell. You want both programs running simultaneously. That's how I see the future.
Jessica, Inder, I'll let you kind of respond or share any thoughts or feedback, especially Jessica being on the front lines. I mean, How do you see Honeybee evolving? Do you want to go as far as Anish is talking? You kind of alluded to what other countries are capable of doing on the ground as a source of frustration already. I mean,
yeah, I think it's absolutely necessary. I think what he's saying is spot on. We have to communicate as a team in order to, number one, cut costs for people, but provide better care. Our advocates are essentially doing that now. Our pharmacists are doing that now, and we could be doing more. We should be allowed to order testing, conduct and interpret results. We can counsel patients. We can initiate basic treatment for infectious diseases where it's appropriate. There's so much more that we can do if we work together. But there's huge fragmentation in our system. And a lot of that is like Anish mentioned, tied to our payers, and it's tied to what we've been doing for decades and decades. And there is a big part of our healthcare system that is just stuck in like 50 years. It's the time of 50 years ago. As you know, at our pharmacy, we, like Inder mentioned, we still have to deal with faxes. When we are trying to build technology to move ahead, and we're held back by things like that, by faxes and by archaic things that we're stuck having to use because other parts of our healthcare system are stuck there.
Do you feel like you could also, based on what you do, being on the ground floor, reaching out to customers directly for their pharmacy needs, be a part of an early warning system that Inder was referencing? That you're seeing things maybe ahead of time, but not able to hear that data, so that's another disconnect?
Absolutely. And we especially saw that happening during COVID because pharmacists are seen as this place where you can go where you don't have to pay anything. You have to think of it from a patient perspective. I want medical advice. I need help. What kind of professional can I see and pay the least amount of money and still feed my family? And the pharmacist is usually the first one that comes to mind. So we can absolutely do that. And you know, it's the future. It's what we have to do. It's hard. It's going to be really hard, but it's what we have to do.
So whenever there's, go ahead.
Ken, I was just going to say, I think one thing that's really important here is actually business model, right? You can imagine, I loved the vision that Anish painted just now, right? But let's take it down to an individual patient level. Imagine a world in which you have a wearable for hypothetical reasons. You have a wearable that's sensing your biometric data. Something changes, and all of a sudden there's outreach from the system to that individual. Hey, this has changed. This is what we'd recommend. Should we send you, maybe you have a slight increase in your body temperature. It's an early sign of a fever. Let's take an epidemic example, right? Could be a sign of a GI bug, could be a sign of a respiratory disease. We don't know, but we see in your local area that other people have flu-like symptoms, right? So we're getting an early warning indicator using Bayesian theories, right? There's a prior probability that you might have flu because the people that you've interacted with in your local area have flu. And we've seen just a slight increase in temperature. So we're going to send you a diagnostic today, right? We send it out to you using Amazon same day. So they get it within 2 hours, and they take their diagnostic. It reads out on the smartphone, and it triggers a series of activities, an immediate prescription for an antiviral from Jessica's organization, bypassing potentially a doc prescription because we have a confirmed diagnosis. We have this full technology, this end-to-end solution that triggers, and the same Amazon same day service sends that antiviral to that person, right? This is what's possible with healthcare. But the challenge is creating the incentives regulatorily. I don't know if that's the right word here. The regulatory scheme needs to create the right incentives. And then we need the entrepreneurs to create the business models that are going to enable that kind of vision for the future. But that's where we have a real amazing opportunity to take this momentum, this tremendous growth over the last year in telemedicine, online services, virtual care, and take it very rapidly to the next step. And I think it's incumbent upon us, and it's incumbent upon the regulatory regimes to really create those right incentive structures. That's what's possible. That's what's possible. And let me just add one last thing, which I think is really important. And I hit on it earlier. That vision sometimes leaves out huge swaths of the population that are underinsured, underserved, these multi-generational diverse households. I think what the epidemic has shown, I hope what the epidemic has shown, is that you need an underserved strategy. Because if you don't take care of a community that is adjacent to another community, it's just going to cause another flare-up in illness. And those richer communities are going to have downstream, with people with underlying conditions, seniors are going to be hospitalized again. We cannot leave big swaths of our population out of this vision. this is a vision to be healthier together. And I think the pandemic has emphasized that we need to be healthier together. It's not one group versus another. We can't leave those underserved communities out of the picture.
So we only have a few more minutes left. I kind of want to take a different tack on the roadblocks and challenges, right? You've talked a little bit, all three of you, about the kind of institutional barriers, right? Whether the technology is slow and outdated, whether there are kind of systems in place, whether they're providers or hospital systems, kind of a bit of a challenge. Talk to me about the negative impact that a lack of trust and misinformation is playing in expanding access to care and moving the needle on a lot of what you've talked about. People not wearing masks, people questioning vaccines, people questioning science. It's real. How does all that play into what you're trying to do? And we just round robin, whoever wants to go first. And I mean, Jessica, you must get calls about people asking for, like, you know, whatever mystery cocktail was given to whomever to get over COVID, right? I mean, what kind of, how much of your time or energy are you spending on stuff? I mean, maybe it's not as real as I'm thinking, but I kind of think it's.
No, it's very real. No, you're spot on. It's real. It's absolutely real. And I think we're fielding, you know, a lot of calls in the last year from patients about mistrust about vaccines, about the drugs they're taking, about whether or not they should wear a mask, whether their 100.3 fever is still okay for them to go to work. There has been so much information thrown at people during this time, and it's caused even more confusion. You know, we worked very closely with the Lupus Foundation, because in the middle of the pandemic, I think it was summer of last year, we started seeing a shortage of the drug I mentioned before, hydroxychloroquine, for patients who have lupus and rheumatoid arthritis need this drug to survive. And we started seeing a shortage of it because people were hoarding it and prescribers were hoarding it. And there was so much information being thrown around from a lot of different parties and people on the news and Facebook and what else. I don't know where else do patients get their information these days, but we were really on the front lines of, like, calming people's fears and saying, no, this is a real virus, stay home, wear your mask, wash your hands. You don't need to take hydroxychloroquine. It hasn't been proven yet. In that time, the studies hadn't come out yet, but just stay home. And we were getting hundreds of calls a day, even from prescribers, believe it or not, saying, hey, can I have 180 of these tablets? I'm like, for what? There was just so much confusion and then mistrust. And we've done a lot of work to kind of calm people's fears in the past year. But I think because of the way our healthcare system is set up, that's something that's going to take years to get over, is the mistrust of the system and healthcare. And you know, if you have to get an X-ray these days, it's like the anxiety of how much it's going to cost just to get an X-ray is unreal. And so it's going to take time, but I think we can get there.
That's great. Inder, and then we'll close out with Anish.
There's no doubt that this is a challenge, right? And I think our job is to educate. And, you know, we need to empower individual decisions. Even in those environments in which we've seen folks that are less likely to mask, we've personally found that when we provide insights to households in those populations, they are reacting the way you would expect them. There's a rise in illness levels. People are washing hands more. They're disinfecting more. You know, this is the natural response of a parent, or for that matter, a teacher or a school nurse. And so I'm encouraged, even despite the political challenges, the kind of polarization that we're seeing, that, you know, again, if we educate, if we empower individuals, I think we're going to see the right responses in healthcare. And again, from our experience in doing that, in giving people gentle nudges to say, hey, there's a rising level of illness in your area, these are actions you could take. We've seen those actions, you know, come to fruition. So I understand the challenge, but I think our job is really to educate and empower the individuals. I think that's the best we can do, and it's the right thing to do.
I may piggyback to say empower for what? To designate a trusted quarterback for their care. So in the Obama administration, we launched a proposed rule that the Trump team took out on the 401k world, establishing a fiduciary rule that says that if, financial services are complex, you might refer to someone who's an advisor. That advisor should give you advice that is in your best interest. So I would argue a big bright light in this social media disinformation, politicization world is through the fog. There is this notion that everyone has their own personal trusted fiduciary. It could be Jessica's pharmacist advocates. It could be a doctor. It could be my insurance company care manager. Someone is a trusted voice that will convince me of the things that I need to do that are in my best interests. And one way to pierce the veil of the broader macro dysfunction of disinformation is to really build back the concept of trust. And I think, frankly, the healthcare delivery system is going to be anchored on trust. I'm excited to know whether or not I'll trust my local, pharmacist, Walmart, Walgreens, Jessica, whomever, that they're the folks people interact with the most. And frankly, maybe they're the best designed for routine questions. I don't know, maybe not, maybe it's somebody else. But I would love a health system that acknowledges that there should be a quarterback and there's a business model for the quarterback to manage the care. And if the quarterback is successful at managing the care, that we can actually reward them with the results. That's possible, Ken. We just got to connect a few of these dots.
Yeah.
Well, listen, I'm so grateful to all three of you for coming on our coffee talk show today. Clearly just scratching the surface on the healthcare sector, but grateful for all the work you're doing. Thank you to everyone tuning in today. Our next Coffee with Ken is going to be next week. We're talking tourism with Roger Dow, the CEO of US Travel, and Elliot Ferguson, CEO of Destination DC. In the meantime, practice social distancing, wash your hands, wear a mask, and get a vaccine. Thank you all.